I'm Marcus Williams. I'm a cardiac surgeon in Bristol, Tennessee. Our panelists are Tom Wozniak at Indiana University Health Systems and Dr. Joseph Schwissenberger at University of Kentucky. The name of this talk, the name of this presentation is ECMO in Your Hospital. And for this presentation, this is going to be limited to use of ECMO in adult respiratory failure, pulmonary failure. I have nothing to disclose. ECMO for the use of respiratory failure is not a topic that's been presented a lot in the main meetings, but is a topic in critical care. And so I thought it would be good to give a brief history of ECMO for the use of respiratory failure before presenting the case. In 1972, ECMO was first used successfully to treat a patient with post-traumatic lung injury. This was in Santa Barbara, California, and it involved a 24-year-old gentleman who was involved in a motorcycle accident, and had a tear of his aorta. He developed adult respiratory distress syndrome, and 4 days later, and underwent veno-arterial ECMO for 75 hours and was able to be successfully treated. Subsequent to that, there were several scattered articles, and then between 1974 and 1979, there was a multi-center NIH randomized trial comparing ECMO to conventional ventilation in adult patients with ARDS. And this involved 90 patients across 9 centers. And in this study, there were over 90% mortality in both groups. This also used veno-arterial ECMO. In 1994, there was a randomized trial by Morris in Salt Lake City who demonstrated no significant outcome difference between VV ECMO and conventional ventilation in terms of treating ARDS patients. It was a single-center study with 40 patients. The thing about this study is that in both arms, the survival rate had improved significantly. So this indicated more the improvements in the medical management of ARDS. After that study, the investigation of ECMO in this country for the treatment of adult respiratory failure pretty much ceased, but it continued in Europe. Then in 2009, a study in Great Britain, the CESAR study, the conventional ventilation or ECMO for severe respiratory failure trial, was presented. This involved 180 adults. It was a multi-center study and was randomized. It demonstrated an improvement of 63% disability-free survival with ECMO compared to a 47% with conventional treatment. There were problems with the study. It showed that there were only 75% of the patients who were randomized and referred for echo actually were placed on ECMO. The way the study was is that there was only one center that did ECMO, and there were several centers that did the conventional trial, and the center that did ECMO was not involved in doing the conventional trials, there was no consistent management protocol for the ventilator managed patients. Then in 2009, with the H1N1 flu pandemic, Australia and in New Zealand, they had the study of extracorporeal membrane oxygenation study, and this was a retrospective study of 201 patients who were confirmed with the H1N1 flu and were treated for respiratory failure. 68 of those patients received ECMO, and interestingly, in 49 patients, ECMO was initiated at the outside hospital and was transferred to the ECMO center for further treatment. And they had a survival at discharge of 70%. With these last two studies, this really perked the interest in renewed investigation of use of ECMO for the treatment of adult respiratory failure.
So, Marcus, to be fair, that 40-year-old data from the first NIH study, we had no idea what we were doing. Everybody bled to death. The 20-year-old study, Alan Morris was a pulmonologist that had no idea how to do ECMO. And the CSAR trial was at a center of excellence where they had markedly improved survival based on their critical care management and the addition of ECMO. So I think you're right in the fact that you've given a wonderful historical presentation. But in the present now, we're seeing 60% survival in adults that are supposed to have exhausted all medical management. So that's the setting, right?
Right.
Okay.
The case is a 42-year-old African-American male chef with a history of hypertension, obstructive sleep apnea, and BiPAP noncompliant. He has a 4-day history of dyspnea culminating in lethargy. He was brought by his family to the emergency department. Home meds include carvedilol, amlodipine, and aspirin. He has no previous surgeries or significant family history. He was morbidly obese, and he smoked half a pack of cigarettes a day for 10 years. On presentation to the outlying hospital, he had a temperature of 100.2 with a heart rate of 105, blood pressure 140/78. Blood gases revealed a pH of 7.15 with a PCO2 of 138 and a PO2 of 61. As mentioned, he was morbidly obese. There was no edema. Echo showed normal LV function with cardiomegaly. At the hospital in the emergency department, he was placed on BiPAP, but he subsequently vomited, leading to aspiration pneumonitis and acute lung injury requiring intubation. His relevant data include BNP of 55. He had an elevated D-dimer. His influenza testing was negative. On the ventilator, he had a pH of 7.2 with a PCO2 of 78 and a PO2 of 86 on 80% oxygen and a PEEP of 15. His white count was 18,000. This is his chest x-ray after he required intubation after aspiration. During his hospital stay at the outlying hospital, they had difficulty with ventilation and oxygenation. His PO2 FiO2 ratio was 55. He was on a bicarbonate drip. He was having worsening hypotension, requiring significant doses of norepinephrine. He had acute renal injury. Echo at the bedside continued to show preserved LV function. He was placed on a heparin drip, thinking that he might have pulmonary emboli, although his Dopplers were negative. He had very high peak and plateau pressures up into the 40s. This was his CT scan prior to transfer. Status upon transfer, his pulse was 71 with the respirations of 14. His blood pressure was 70/46 on Levophed, and his SATs were 49%. His gases are as shown. The treatment was immediate placement on VV ECMO in the ICU using a single-site dual-lumen cannula via the internal jugular vein. And after 34 minutes, his pulse was 86, his blood pressure was 115 over 67 with a saturation of 97% on 40% oxygen and no inotropes.
Marcus, you're a hero because that patient was about 30 seconds away from a cardiac arrest.
I must say that this is a case given to me by Dr. Wozniak.
Yeah, I'll make a quick comment. This
you're a hero.
I'm the hero. This patient was at another hospital within our town, but only about 5 miles away, and it was at a teaching hospital. And the newly ordained critical care staff physician, had just graduated from our pulmonary critical care residency, and he was the one that initiated the consult and transferred the patient over, rode over with the patient in the ambulance. So we had already made arrangements to place this patient on ECMO prior to transport.
Well, the good news is you trained him well to initiate the transfer. The bad news is you didn't teach him to react quick enough.
Well, I think this was 3 days. You're in that window, I think.
But did you see that CAT scan and those vent settings?
Mm-hmm.
I mean, they were pounding those lungs. There was nothing ventilating. He had no shot at recovery. So the good news is you trained him.
Okay. This is just a visual of his vital signs when he arrived at Indiana University, pre and post ECMO. Okay. This is a picture of the setup. You have the console, and this is the inflow into the pump oxygenator and the outflow. There are a couple of ports here that you can have hookups for. In this patient, he received CVVH for dialysis and fluid management. It's a typical setup. This is the bicaval cannula that was used. It has 3 ports, 2 peripherally for the superior vena cava and the inferior vena cava, where the venous return is taken to the pump and then is brought back through a central opening that's positioned right adjacent to the tricuspid valve that is oxygenated. We can get into other cannulation techniques later. This is a diagram of how it's set up. It's placed into the superior vena cava. This is his head. And you have 2 ports right here, the inflow and outflow. Patient was supported on ECMO for 9 days with gradual improvement in his chest X-ray, peak pressures, and gas exchange. As mentioned, he had CVVH hooked up for fluid removal, and on ECMO day 9, his gases were 7.42 with the PCO2 of 40 and a PO2 of 65 with the ECMO settings of 21% FiO2 and a sweep or gas exchange of 1.5 liters per minute. And he was on 40% FiO2 on the ventilator and a PEEP of 5. After decannulation, his gases were 7.37 with an oxygenation of 91, PCO2 of 47 on 50% oxygen and PEEP of 8. He subsequently had a tracheostomy after decannulation for airway protection.
So let me ask you, why didn't you trach him a little earlier so you could walk him around, move him, and get those muscles conditioned?
Well, he was mostly adipose, not muscle, was one challenge with this individual. I think getting him out of bed was going to be physically challenging regardless of whether he was even intubated. And also he was requiring a fair amount of sedation and paralytic to run this ECMO circuit on him, and we didn't feel that getting him trached was going to get him out of bed any sooner. He was pretty much limited by his lung disease.
But if he were a little bit smaller, would you have considered it?
If we'd have thought we had a good chance of getting him up and walking him around, yes.
Yeah, we're real impressed with the recent medical literature and the recent studies showing about deconditioning of the diaphragm and skeletal muscle, and we try to get him up as much as we can.
Okay. This was his chest X-ray post right prior to decannulation, and this was his chest X-ray prior to discharge to rehab.
I'll just comment quickly on the sternal wires. Those that are observant will notice that this patient now has sternal wires. He unfortunately developed a tracheoinnominate fistula about a week after being decannulated that required urgent repair.
Did you put the trach in?
No. It was a
I don't know whether to
percutaneous
say
trach.
good or bad.
All right. So I have a question. As mentioned in the Australia, New Zealand, they transferred patients. The ECMO was in the outlying hospital. They were placed on ECMO prior to transport. This patient was to the point where that probably would have been helpful. Are there what are your feelings about setting up where patients can be started on ECMO and then transferred to a ECMO center?
We had discussed that in this particular case, but the reality of it was that the other institution did not have ECMO capabilities. It's a non-open heart center. They didn't even know what an ECMO circuit looked like. We didn't have privileges at that hospital, and we did take a bit of a risk, obviously, in transferring this patient over.
There's a paper presentation on Saturday morning by the Columbia Presbyterian Group on 100 successful ECMO transports that you should come to. And it shows how successful you can be at going to an outside site and plugging these patients in to ready them for transport. That said, I can't afford to hire the surgical manpower, the extra PAs, the extra respiratory therapists, the extra perfusionists at my institution to jump in and run off to another institution. So we're in the same boat you are.
Patients how do you determine patients that are not candidates for ECMO? When do you decide a patient is not a candidate for ECMO?
Well, obviously there are a lot of things you have to take into account. Certain comorbidities, like any other procedure, you would, if they have non-survivable or irreversible mental status changes, things like that, you're not going to want to put somebody on. But I think more importantly, you have to decide whether or not you're going to benefit the patient, and paramount to that is having a reversible process, which unfortunately you don't always know whether or not it's reversible. But I think the things that most people will agree on is that if you wait too long, the likelihood of getting a recovery is bad, and we use about a 5 to 7 day window of maximum lung protective strategy, still with a PF ratio of less than 100. I think the interesting question is are people getting put on too early? Some of these folks that get put on really early may do just fine with continued respiratory management. So I'd be interested to hear your comments on that.
Well, I think you hit the nail on the head. To the pulmonologist intensivist, there's always one more dial to turn or one more drip to try. So I think the key is to recognize the fact that you've hit maximum medical management, you're no longer getting any bang for the buck, and the patient is deteriorating as this one was doing. I would have put that patient on ECMO a day earlier. I think that the multiple studies have shown that early placement gives you the opportunity to make a more intelligent decision rather than be faced with a patient that's about to code. And I think that's the key. Everybody in this room is more expert in critical care of the lung and more expert at cardiopulmonary bypass or extracorporeal support management than any intensivist, I promise you. So you have to use your instincts and your knowledge of critical care and your judgment to know when a patient is either has no recoverability or their comorbidities are too overwhelming, or the fact that there's just anybody can turn one more dial. You can always crank up the PEEP. You can always crank up one more setting. You can even flip them in prone position, which doesn't do much. But the key is that you recognize the fact that you've hit a plateau in terms of advancement in their therapy.